Your doctor scheduled a routine test. You showed up. You were doing everything right. And then a phone call changed everything. Not because something was wrong with you, but because of the test itself. That is not a hypothetical. That is what happened to Dorothy. That is what happened to Robert. That is what happens to millions of Americans over 70 every single year. And after more than a decade as a geriatric medicine specialist, I've decided I can't stay quiet about it anymore. Here is the truth that modern medicine has been brutally slow to admit. After the age of 70, some of the most routine checkups your doctor orders without even blinking. Tests you've been faithfully scheduling for decades because you believed you were being responsible, don't just fail to help you. They trigger a chain of events. More tests, more procedures, more medications, real physical side effects, and psychological harm that can rob you of your independence, your confidence, and your peace of mind. All from a test that found something that was never going to hurt you. I know that sounds impossible. Your whole life, you've been told that early detection saves lives. More testing equals better health. Catching something early is always better than missing it. And for most of your life, that was absolutely true. But at 70, the math changes. Your body changes. The risk-benefit calculation for screening flips in ways that your doctor may not even be up to date on. And nobody is telling you this. My name is Dr. Anderson. I'm a board-certified internist and geriatric medicine specialist. And over the past decade plus, I've worked exclusively with adults over 65. I've seen remarkable outcomes. And I've held the hands of patients whose lives were derailed, not by disease, not by negligence, but by perfectly standard medical recommendations that nobody stopped to question. Today I'm going to walk you through 5 medical checkups that the American Geriatric Society and other leading organizations now say should be reconsidered or stopped entirely after age 70. What the research actually shows, why these tests cause harm in this age group, and most importantly, what you should do instead. Before we go any further, comment below and tell me how many routine screenings or checkups you go to each year. Just drop a number. I read every comment, and I think you'll be surprised how many people in this community are going through the exact same experience. Now let me tell you about Dorothy, because her story is going to reframe everything I'm about to share. Dorothy was 74 years old, retired schoolteacher from Phoenix, Arizona, still gardening, still driving herself everywhere, still the sharpest person in any room. She exercised 3 times a week, took her medications, showed up to every appointment her doctor scheduled. She was doing everything right. And that, as it turned out, was exactly the problem. Her physician had been ordering the same full battery of annual screenings he'd ordered since Dorothy was in her 50s. She never questioned it. Why would she? He was her doctor. Then one result came back with what he called something we should look into more closely. Nothing definitive, just a number slightly outside the normal range. Dorothy told me later, I walked into that office feeling completely fine. I walked out feeling like I might be dying. What followed were 6 weeks of specialist appointments, a biopsy, and a procedure to address something that, and this is the part that still breaks my heart, her own oncologist eventually told her had almost certainly been there for years and would likely never have caused a single symptom or shortened her life by 1 day. The procedure left her with nerve damage in her left arm, for months of physical therapy, and an anxiety that has never fully gone away, an anxiety that didn't exist before any of this began. This is not rare. I see versions of Dorothy's story every week. It has a name, overdiagnosis, finding and treating conditions that would never have caused harm. A study published in the British Medical Journal in 2023 estimated that overdiagnosis affects millions of older Americans every year, leading to cascading treatments with real physical and psychological consequences for conditions that posed no actual threat. Here is the good news, and I want you to really hear this. This is not medicine failing you. This is medicine evolving, and you now having the knowledge to be a smarter, more empowered participant in your own care. Research published in the Journal of the American Geriatric Society in 2022 found that older adults who worked with their physicians to reassess which screenings were still appropriate reported significantly higher quality of life. And here's the part that surprises people, comparable or better health outcomes. Not worse, better. Because after 70, the goal isn't to find every abnormality. The goal is to protect your function, your independence, and your time. So let's get into it. The first one might genuinely shock you. because it is probably the most universally recommended test in American medicine for older men. Routine PSA screening for prostate cancer in men over 70. Before you move on, especially if you're a man who gets this annually, or a woman watching for your husband or father, please stay with me, because the reasoning here applies to everything else on this list. The PSA test measures a blood protein that can indicate prostate cancer. For decades, we told men over 50 to get it every single year. Catch the cancer early, treat it, save a life. Straightforward, right? Except here's what the data shows specifically for men over 70. The United States Preventive Services Task Force, the most respected independent screening authority in America, recommends against routine PSA screening for men 70 and older. Not because they don't care about prostate cancer, because the evidence shows the harms of screening in this age group consistently outweigh the benefits. Here's why. Studies show that 50 to 70% of men over 70 have some prostate cancer cells present, but the vast majority are what we call clinically insignificant. That's a medical way of saying they grow so slowly that statistically, these men will die of something entirely unrelated before this cancer ever causes a single symptom. The problem is that a positive PSA result can't tell us which cancers are dangerous and which aren't. So when the number comes back elevated, we biopsy, we scan, and too often, we treat. And the treatments are not gentle. A study in the New England Journal of Medicine in 2022 found that among men over 70 treated for low-risk prostate cancer, more than 40% experienced significant urinary incontinence, and over 30% experienced sexual dysfunction, for a cancer that most likely would never have affected them at all. Robert was 77 years old, a retired firefighter from Columbus, Ohio. Active, healthy. His PSA came back at 5.1, slightly elevated. 6 months of follow-up later, he had surgery for a cancer his urologist would later acknowledge was very low risk, with watchful waiting as a fully appropriate alternative that was never offered. Robert now wears protective pads daily because of incontinence. He told me, "I went in for a routine blood test. I feel like I left half of myself behind in that operating room. What should you do instead?" If you're already tracking a PSA baseline, work with your doctor to evaluate whether continued screening makes sense for your specific health profile and family history. Ask explicitly about watchful waiting. And if low-risk prostate cancer is found, always get a second opinion from a urologist who specializes in older adults before any treatment decision. That single step could spare you from a procedure you never needed. Now, the second checkup affects both men and women, and it's one that carries enormous emotional weight. Routine colonoscopy screening in adults over 75. I want to be careful here, because colonoscopies have genuinely saved lives, and I am not dismissing that. What I'm questioning is the automatic, no symptoms necessary colonoscopy for someone over 75 who has had clean prior screenings. The American Cancer Society, the Preventive Services Task Force, and the American Geriatric Society all recommend that routine colonoscopy screening stop at 75 for average-risk individuals with normal prior results. Between 76 and 85, it should only happen based on individual circumstances. Why? Because after 75, the risks of the procedure and its bowel prep begin to meaningfully outweigh the statistical benefit for most people. As we age, the tissue of the colon becomes more fragile. A study published in the journal Gut in 2021 found that adults over 75 undergoing routine screening colonoscopies had a perforation rate nearly 3 times higher than those under 65. And the bowel prep, that day of drinking large volumes of laxative solution, can cause severe dehydration and dangerous electrolyte imbalances in older adults, especially those on heart or blood pressure medications. To be absolutely clear, if you have symptoms, rectal bleeding, unexplained weight loss, significant bowel changes, a family history of colon cancer, or a history of polyps, that is an entirely different conversation. I'm speaking specifically about the checkbox colonoscopy for someone with no symptoms and prior clean screenings. Margaret was 79. Her new physician recommended a routine colonoscopy, her first in 8 years, since her last one at 71 came back completely clean. The procedure found nothing, but the bowel prep caused severe dehydration that triggered a dangerous drop in her blood sodium levels. She was hospitalized for 4 days. Her cognition was affected for nearly 2 weeks. Her daughter told me, "We did everything right. I still can't believe this happened. Ask your doctor this. Given my age, my prior screening history, and no current symptoms, is there a less invasive alternative? There is. It's called FIT testing, a simple annual stool test done at home that evidence shows can effectively detect colorectal cancer without any procedural risk whatsoever. Ask about it. The third checkup surprises people most because it seems completely harmless. Routine annual EKGs, electrocardiograms, in healthy older adults with no cardiac symptoms. 90 seconds lying there while stickers read your heart's electrical pattern. How could that possibly cause harm? The harm doesn't come from the test. It comes from what follows an abnormal result. As we age, our hearts change electrically in ways that show up as abnormalities even in completely healthy people. Minor conduction changes, small ST wave variations. These findings are enormously common in people over 70 who have zero heart disease. But when they show up on a routine EKG, they trigger a cascade: stress tests, echocardiograms, cardiologist referrals, sometimes procedures, each carrying its own risks. The American College of Cardiology explicitly states that routine EKG screening in low-risk, asymptomatic older adults is not recommended. A major review in JAMA Internal Medicine in 2022 found it led to no improvement in cardiovascular outcomes, but was associated with a 40% higher rate of subsequent cardiovascular testing. Henry was 73, a retired engineer from Denver. No chest pain, no palpitations, no symptoms whatsoever. A routine EKG showed a left bundle branch block, a variation his cardiologist acknowledged was almost certainly age-related and benign, but felt required evaluation just to be safe. The cascade led to a cardiac catheterization. 2 days later, Henry had a stroke, a known risk of the procedure. He spent 6 weeks in rehabilitation. He told me, "I drove myself to that EKG appointment. I didn't drive again for 8 months." The question to ask before any EKG: are we ordering this to investigate a specific symptom or concern, or is this routine? That distinction changes everything. Before we continue, hit that subscribe button right now if you're finding this valuable. This community is built on people over 60 who want accurate, updated information so they can walk into their doctor's office as informed partners, not passive recipients of whatever gets ordered. Welcome to this family. The fourth checkup affects tens of millions of older American women. Repeated DEXA bone density scans in women over 75 who are already on medication for osteoporosis. Let me be precise. The initial DEXA scan at 65 to establish a baseline and diagnose osteoporosis is absolutely appropriate, and I fully support it. What the research now questions is repeating these scans every 1 to 2 years in women already on stable medication, when those repeat scans rarely change management, and when the results can trigger medication adjustments that carry real risks in elderly patients. The bisphosphonate medications used for osteoporosis, drugs like alendronate, are highly effective in younger postmenopausal women. But in women over 75, extended use has been associated with 2 rare but serious complications: atypical femur fractures, stress fractures in the thigh bone that can occur with minimal trauma, and osteonecrosis of the jaw. A study in the Journal of Bone and Mineral Research in 2023 found that routine repeat DEXA scanning in women over 75 already on therapy rarely changed clinical management, but frequently triggered prescription adjustments, each carrying its own risk profile in patients whose bodies are far more medication sensitive than they were at 65. Eleanor was 81. She'd been on a bisphosphonate for 12 years. A new physician noticed a slight decrease in her HIP score and increased her dosage. 6 months later, Eleanor developed an atypical stress fracture in her right femur, a dull ache in her thigh for weeks. Then it suddenly snapped while she was walking to her kitchen. Surgery. 3 months in rehabilitation. She told me, "I had been taking that medication for over a decade because I was afraid of breaking a hip, and then I broke my leg from the medication." If you are over 75 and on osteoporosis medication with stable scores, ask your doctor 2 things. How will the result of this next scan change what we do? And, am I a candidate for a medication drug holiday? After 5 to 10 years on bisphosphonates, a drug holiday is a recognized, guideline-supported option for lower-risk patients. That conversation could meaningfully reduce your risk. And the fifth checkup is the one I feel most passionately about, because it involves something deeply personal and almost universally misunderstood. Routine cognitive screening, standardized memory tests like the MOCA, administered as a checkbox item during annual physicals in older adults with no reported concerns or symptoms. I want to be absolutely clear. If you or your family have noticed changes in memory, language, judgment, or daily function, please pursue evaluation. That is different from what I'm questioning. I'm questioning the trend of administering these tests routinely to every patient over 70, regardless of symptoms, as a standard line item on the annual physical. Here's the problem. Current cognitive screening tools have a significant false positive rate in older adults with anxiety, depression, sleep deprivation, certain medications, or hearing loss. And a false positive on a cognitive screen is not just a number to watch. In practice, it triggers a cascade that can be psychologically devastating. Specialist referrals, neuropsychological testing, MRIs, and sometimes diagnoses of mild cognitive impairment that carry a stigma so heavy that patients change their entire lives based on them. They stop driving before they need to. They withdraw from social activities. Their anxiety and depression worsen. And anxiety and depression, the research is clear, are among the most powerful accelerants of actual cognitive decline. The United States Preventive Services Task Force concluded there is insufficient evidence that routine cognitive screening of asymptomatic older adults improves outcomes. A follow-up study in JAMA Neurology in 2022 found that older adults diagnosed with mild cognitive impairment through routine screening versus those whose concerns arose from actual functional changes were significantly more likely to develop depression and significantly less likely to engage in the social activities that protect brain health. Franklin was 72, sharp, engaged, active. A routine cognitive screen flagged a borderline score after a poor night's sleep, with test anxiety, and with mild hearing loss that made it hard to catch the instructions clearly. His doctor referred him to a neurologist. He was given a preliminary diagnosis of mild cognitive impairment. Franklin stopped going to his book club. He stopped volunteering at the library where he'd worked 3 days a week for 6 years. He stopped driving on the highway. His daughter called me in tears 3 months later. My father was the sharpest person I knew. Now he's afraid of himself. When comprehensive neuropsychological testing was done 8 months later, the specialist found no meaningful evidence of neurodegenerative disease. But the 8 months of withdrawal and isolation, that part wasn't reversible. What should you do instead? If you have no functional concerns, managing your finances, medications, schedule, and social life without difficulty, and no one close to you has raised specific worries about your memory or judgment, have a direct conversation with your doctor about whether a symptom-prompted approach makes more sense for you than routine annual screening. And if a cognitive screen comes back borderline, insist on comprehensive neuropsychological evaluation before any diagnostic label is applied. A 10-minute test in an exam room is not a diagnosis. Pro tip: before any cognitive screening, tell your doctor about your sleep the night before, your current anxiety level, and any significant stressors in your life. This context is medically relevant. A thoughtful physician will factor it in. Now let's put this all together. After age 70, the relationship between medical testing and health outcomes changes fundamentally. The 5 checkups we covered today share one common thread. They're well-intentioned. They have genuine value in the right circumstances, but applied automatically, as checkboxes on an annual visit form. They generate abnormal findings that trigger cascades of testing and treatment whose risks often exceed the benefit for this specific age group. This is not about skipping your annual physical. It is about walking into every appointment as an active, informed partner. For any recommended test, ask 3 questions. What specific condition are we screening for, and what is my personal risk? If this comes back abnormal, what is the next step, and what are the risks of that step? And if we choose not to do this test, what are the realistic consequences? Write those down. Bring them with you. Tonight, look at the tests on your next appointment order. Identify any test from today's list. Before you simply agree, ask those 3 questions. Comment the word empowered below if you're going to do this. I want to know. Let me leave you with Gloria. She was 76 when she came to see me after being bounced through 3 specialists over a year and a half, following a series of routine tests that generated a cascade of procedures. She was exhausted, frightened. She told me in our first appointment, "Dr. Anderson, I used to wake up every morning feeling like myself. Now I wake up feeling like a patient. I don't know who I am anymore outside of these appointments." We reassessed everything together. We worked with her specialists to identify what truly required active management. We stopped 4 medications the evidence no longer supported. We dramatically reduced her testing schedule. We focused on what the evidence consistently shows actually extends quality of life after 70. Physical movement, social connection, sleep, good nutrition, and the profound benefit of feeling in control of your own health. 6 months later, Gloria called my office. She'd gone back to her watercolor painting class. She'd taken her grandchildren to the zoo for the first time in 2 years. She told my nurse, "Tell Dr. Anderson I woke up this morning feeling like Gloria again." That phone call is why I make these videos. You deserve to feel like yourself. You deserve a medical relationship that protects your independence and your joy, not one that turns you into a collection of abnormal values to be endlessly chased and treated. You have far more power in that relationship than anyone has told you. And what you learned today is how you begin to use it. If this video helped you, please share it with your spouse, your sibling, your friend, your parent. This conversation could change how they show up at their next appointment, and it might protect them from a cascade they never needed. Subscribe if you haven't already. New videos every week, accurate and updated. The kind of information that helps you age with clarity and real confidence. And comment one of 3 things right now. Screening, if you've ever been through a medical cascade following a routine test. Questions, if you're bringing those 3 questions to your next appointment. Or Gloria, if this video made you feel less alone. Bookmark this video. Come back to it before your next physical. Share those 3 questions with your doctor. Thank you for watching all the way through. You are not just a patient. You are an informed adult who deserves clarity, respect, and a healthcare team that treats you that way. This is Dr. Anderson. Take good care of yourself. I'll see you in the next video.